bias, and I want to welcome you to our webinar with Elizabeth Lutz, who will be talking to us about the Pathways Community Hub, a model for connecting patients to NMDOH services. The Pathways Community Hub model is a transformative and sustainable community-based care coordination network. One powerful part of the Pathways Community Hub model is the infrastructure to track risk from identification through mitigation and link payments directly with outcomes. Payments are benchmarked as outcome-based units, which each risk plan or pathway is assigned a unique billing code and modified based on the complexity of completing the pathway. This model is one example of a financially sustainable approach to addressing non-medical drivers in the community. We're so happy you joined us today to learn about this topic. To tell us more, I want to introduce our consortium program manager, Jackie Klotz.
Thank you, Charles. I'm grateful that you all have joined us today for this session of our webinar series. This meeting will be recorded and shared on your YouTube channel after the event, and we will also email you a copy of today's slides for your reference. There will be time after today's presentation to answer your questions, but as questions arise, please feel free to post them in the chat, and we're going to monitor them to make sure we have a robust discussion at the end. Our presentation today is delivered by Elizabeth Lutz, the Executive Director of the Health Collaborative, Bexar County's community health leadership organization. The Health Collaborative has served the community since 1997 with programs for health literacy, active living, and immunizations, and they conduct the Community Health Needs Assessment for Bexar and Atascosa counties. Pertinent to today's discussion, they administer the Grow Healthy Together Pathways Community Hub in Bexar County. They launched their Pathways Community Hub in 2018 and since then have served over 2,400 Pathways families to connect them with the community resources they need to achieve health. Please join me in welcoming Elizabeth Lutz, who is here to share her experience with the Community Pathway Hub model. Over to you, Liz.
Thank you, Jackie, and thank you, Charles, for giving us this invitation and providing us an opportunity to talk about the community of Bexar and all the wonderful work that they're doing. Let me shift over to my share screen. All right. And happy Tuesday, everyone. I hope everyone is safe and out of harm's way. If you were impacted by the storm, we are wishing you great recovery in your community. So again, my name is Elizabeth Lutz. I've been with the organization since 2007, serving as their executive director, but a servant leader to our community. It's been my privilege to be a part of this wonderful team. We're going to get started here with a quick overview of the Pathways Community Hub, and I'd like to share a video that sort of gives you the story and gives you a walkthrough of what the Pathways Community Hub model is. And then we'll get into learning a little bit more, taking a deeper dive into how this transformative program is helping community families in San Antonio and the Bexar County area. So with that, let me go ahead and start our video.
Elizabeth, we're not hearing any audio. Is it video muted? Liz, Elizabeth, I apologize. The sound's still not coming through for us. I'm wondering if I can share it from my screen. Is this the video that's on the Growing Together webpage? Jackie, can you hear me?
Yeah, I can hear you. Liz, can you hear us?
Uh-oh.
Is there meant to be sound on the video?
Yes. Is the sound not coming through for you?
Oh,
No.
it is not. Can
Oh,
we?
I wonder. I'm hearing it on my side, and I'm showing share. That's
If you're
We see
wearing
interesting.
the video.
headphones, it may be going through your headphones. But
Oh,
if you want to
sorry.
stop, if you want to pause, Charles, I think this is the
Yeah,
video that's on the website, and he can present the screen, and we could just
flip it back.
run it through that way.
Absolutely.
Let's do that.
Yeah, absolutely.
Thanks
Okay.
everyone for your patience. It's always a Zoom challenge to get all this together. Okay, let's see. Okay, Jackie, are you seeing this?
It has not come up yet for
Okay.
us.
How
There you
about
go. It's loading now.
okay. Liz, which one of
That
these
one,
videos
that
is it?
one is actually, let me see if I can actually do it this way.
Okay.
Disconnected.
Okay. I'll stop my share then.
It's a revised video. Charles, let me see if I just disconnected my headphones, so let me see if
Okay.
Jackie, maybe to your point, it may be that was the issue. Tell me if you can hear this now.
Long-standing inequities exist.
Yes.
Pathways Community
Yes?
Hub Institute.
Yes.
Is that working?
It is.
Yes.
Wonderful. Okay, so I apologize. We tested earlier and didn't even think about the headphones being an issue. All right, take two.
From infant mortality to the burden of chronic disease, long-standing inequities exist. The Pathways Community Hub Institute was established to help communities advance health equity by implementing the PCHI model. Pathways Community Hub Institute innovates with communities to build transformative and sustainable care coordination networks called Pathways Community Hubs. The PCH is community-owned and builds health from the ground up. Its sustainability is achieved through a payment model linked to meaningful and measurable outcomes. PCHI model certification standards provide communities the blueprint for building a Pathways Community Hub to fidelity. A nationally certified PCH improves health, reduces costs, and promotes health equity. The PCH serves as the air traffic controller for community-based care coordination. It is dedicated to optimizing the use of local resources, ensuring greater efficiency and effectiveness in addressing complex health-related social needs. It contracts with funders and existing community-based organizations that employ community health workers to connect with those most at risk for poor outcomes. The PCHI model was designed based on the ability of CHWs to build trusting relationships with community members. The PCHI model provides training and tools for CHWs to identify a person's individually modifiable risk factors and work towards eliminating those risks one by one using 21 standard pathways. A pathway defines the steps needed to achieve a specific measurable outcome. If an outcome is not reached, then a pathway is closed and marked finished incomplete. But the CHW's efforts to resolve the risk are recorded. The PCH shares that information with the community to develop solutions. So, how does this actually work? A CHW finds a community member, Anna, who isn't keeping her medical appointments. After the CHW checks in with her PCH to avoid duplication, she schedules a home visit with Anna. The CHW discovers that transportation is part of what's keeping her from her appointments. Anna also doesn't want to tell her doctor that she isn't taking her medication. As the CHW works with Anna to remove barriers, She opened several pathways to track Anna's progress: medical referral, transportation, medication screening, and a learning pathway about medications. Each pathway stays open until the risk factors are resolved. The medical appointment is kept, transportation strategies are in place, a list of medications Anna is taking is shared with her doctor, and she has a better understanding about her medications. In the model, 50% of payments are directly tied to completed pathway. An outcome-based unit accompanies each pathway and is a measure of the complexity and time needed to resolve the risk. PCHs collaborate with grant funders, government agencies, health plans, and more. This alignment of payment with outcomes is a cornerstone of the PCHI model, providing incentives to address complex health and social needs. Used by communities for decades, studies demonstrate that individuals who are enrolled in a certified Pathways Community Hub have improved health and reduced costs compared to those who are not. The model is replicable and scalable to any population with health-related social needs. Today, the PCHI model is being used in almost half of all states to advance health equity in rural and urban areas. At PCHI, our unwavering focus is on forging connections, dismantling barriers, and supporting healthier, more resilient communities. We firmly believe that every individual deserves access to comprehensive health and social care, paving the way to a healthier future.
Okay. So, as was mentioned in the video, there is certainly a lot of Pathways community sites throughout the United States. The Pathways Hub model itself was founded by Doctors Redding. They were working with communities all over the US and really felt that there was a need for creating something that was going to be able to be replicable and be able to not only continue the spirit of the work of community health workers and lay leaders in communities to support families, but also to find a way to be able to track and measure everything that they were doing, as well as creating a financial structure that would allow for sustainability beyond any kind of existing grant model or other type of funding model in communities. So the information collected over their 27 plus years in existence as an evidence-based model has really lent to quite a bit of literature and research that illustrates and really demonstrates the impact that the Pathways Community Hub model, when implemented to fidelity, can really have in communities. It does so much more, though, with regards to how implementing a model like this really exercises and supports collaboration in a community. And we'll be able to talk about that in just a minute. So again, a little bit about the Health Collaborative. We've been in service to our community since '97. So the term social determinants of health, non-medical drivers of health, all of these terms were things that we had been looking at since '97, being the organization that was responsible for doing an entire needs assessment for our county. So instead of having hospitals do their own assessments every 3 years, we really came to a realization that there was value in being able to share experiences, research, but then also working to support communities at a grassroots level and using existing resources and human capacity in order to be able to do that. So we launched into this project in 2018 through an opportunity that was provided to us by the Georgia State University and Robert Wood Johnson Foundation, where we were learning about health impact investing. And so since then, it has really, again, transformed the lives of our families, but also the integrated and the connectedness of our partners in community, our social service partners, and of course, our clinical teams. With the Pathways Community Hub in Bexar County, we serve all populations. So one of the things that you'll find significantly unique about the model that we've deployed in San Antonio is that we are able to receive referrals right now from just about any type of service industry, whether you are a clinician, whether you are a social service agency, whether you're a health plan, whether you're a city or county. Even we've worked with the Alamo Workforce Board, because in this community, all of us play a part in helping ensure that families continue to stay safe, that they are healthy, and that we have a thriving community. And so for our service area, we did not just specifically target pregnant women, although that is about 80% of our referred clients. We have existing agreements that allow us, again, to serve people from all ages and sizes and across their lifespan. So as was shown in the video, there are really three main areas to this model, and it's very, very simple. You find the clients that are needing this level of intense support. You treat the individual by assessing their needs, having conversations, building relationships, connecting them to the right resources at the right time, and then tracking and documenting all of that work in order for us to be able to demonstrate to our funding partners and our payer partners the impact and, of course, the overall impact to the family's health. So when we say refined, again, we're looking at this as an opportunity where we are right now receiving upwards of about 400 to 500 referrals per month. The Pathways Hub, the Health Collaborative, has a small staff inclusive of a hub manager and a hub coordinator. And up until about last week, we had a hub director, Dr. Derek Anderson, who did an amazing job of being able to further support and strengthen our Pathways Hub. He is now doing wonderful things in another state. We wish him well. But for that, we want you to know that because we've been in service since 2018 with this model, it has been very easy for new partners to engage in many different ways. The hub receives the referrals from our different program partners and funders. We, in turn, then identify where we have capacity to support in community through what we call care coordination agencies. Those could be faith organizations, grassroots organizations, community-based organizations, anyone who already has experience working with a community health worker workforce. That community health worker then is the one to connect with the client who has been referred to the program, and then they do all of the navigation at a one-on-one level with the client. Once there is an identified need, then the community health worker will really coach the individual on taking the necessary next steps in order to be able to secure whatever resource it is that we're trying to support them with. Once we can demonstrate that we have been able to successfully support the client through the journey of receiving services, then we are able to push a report back to the hub that allows for us then to turn around and report to our funder that things have been accomplished. And it is at that time then that these funders are then able to pay for the services that were provided and prove to be successful. Once those payers then provide the funding to the organization, the Health Collaborative as that intermediary, we then turn around and provide that funding back to the agency so that the agency can then continue to support their community health worker to continue to do the work. So these are not considered grant dollars for these organizations. These are truly considered additional revenue to support and augment their existing missions. So who are referral partners? Again, for us, we really see this as a value for any organization and any partner that is interested in supporting individuals through multiple journeys and to target those areas where it may seem are not as important, but truly in this field, we know that they are. So health service organizations are going to be an excellent referral partner, managed care organizations, social service agencies, government agencies, municipalities, community-based organizations, but someone very central is going to be our clinical partners. We know that our clinical partners are already stressed for time. We know that there is an internal process potentially that you're doing to address or to assess for social needs. However, where do you go from there? When that individual leaves your office, leaves your hospital, leaves your emergency room, and even though you've done these screenings for social needs, there's still someone in community that potentially can be that partner to help you continue to support that person to address those needs. Some of the services that our individual families are looking for don't take days. Sometimes things can take weeks, can take months. And in cases like housing stability, it could even take years. And so the linkage of these types of organizations and the linkage of our clinical teams to a community asset that has an independent financing stream to support that person going forward is absolutely where we think we can really make a big difference. Currently, our referral partners, our funding partners include Community First Health Plans, Bexar County, that's our county office, Superior Health Plans, and Aetna Health Plan. We also have recently just received support from Christus Santa Rosa, which is a health system that is going to be referring clients, as well as some of our federally qualified health centers that we're opening up referral access to. So again, you could see that the opportunity for engaging in this level, especially with our clinical and health teams, is really a big growth for us. Again, the description of the care coordination agencies is very important for us to note because health and connection is happening at a community level. We recognize that there are organizations like the health plans or hospitals that are doing their part to continue to stay engaged with their clients even after discharge. But what we find is that most individuals that are living in communities are really connecting to local agencies or local resources before even connecting or calling back their health provider. And so for that reason, we're very focused on ensuring that we're growing a team within community that are the right faces, the right cultures, and the right languages, so that connection and trust can be built almost immediately, and we can make sure that those linkages back to our clinical care team are strengthened. You noted that in the video, there is 50% payments to outcomes, which is the process work and the evidence that we are doing work and that we are connecting individuals to those resources. But the other 50% really is about capacity. And so the Health Collaborative has taken a bold approach to looking for other sources of funding like fee-for-service or capacity grants that allow for us to provide learning stipends for community health workers, emergency fund services for those items that are clearly going to not be met within an emergency response time. And so all of these braided resources, as well as the outcome payments, allow for us to further support impact and growth within the community. So what does the payment structure look like? These are contract-based agreements that we have for services from the Pathways Hub, but also a contract for the services that are rendered at the community level. So each of the care coordinating agencies that we support through this evidence-based program is contracted with very specific standards, very specific scope of work that includes ensuring that they are ready to receive or identify populations that could greatly benefit from this type of care coordination service. We, the Health Collaborative and the Pathways Hub, we are responsible for negotiating the outcome-based unit or the rate dollar for every service activity within the contract period. This includes, and this sort of illustrates that each of these areas have a fee or an outcome-based value assigned. That includes our engagement fee, which is where we do our initial assessment of the individual after they've decided to enroll. The standard visit forms that are done every single month, whether it's a home visit, a phone visit, or a virtual visit. This ensures that we're connecting and reconnecting with the individual and their families, and assessing to see if there have been any changes, or perhaps there's been trauma that's occurred within the 30 days that we would need to make sure that we address very quickly. The 21 pathways, as you saw in the video, these are all of the different ways that we can support the individual, and those are also weighted by the amount of time and the amount of intensity that any of those require. And additional tools is when a organization is very interested in doing additional screening. For example, we may have one of our partners that says, we are going to be sending you our chronic kidney disease or diabetic or pre-diabetic clientele. We would like for you to do an additional screen or assessment for diabetes. And so we can add those as additional opportunities to support the client. And of course, there is a dollar amount that is rated for those tools. Again, we developed the contract with a health collaborative, and the Pathways Hub develops the contract with the payer. We establish a business associate agreement. We ensure that we have a business service agreement, and of course that we are HIPAA compliant, and we develop a statement of work. The payer, however, or the funder, is responsible for really describing and working internally within their organization to determine what is the referral process for them. Who in their organization will be sending the clients? What is the population of service or the special population that they would like to have referred, and so forth. Because we are a HIPAA compliant, we utilize a dashboard that is HIPAA compliant and is HITRUST certified. Only those individuals that are authorized to make a referral will have a secured access and a unique identifier and access points into our care coordination system for referrals. So nothing is ever done outside of this HIPAA controlled environment. We take great efforts to ensure that our response time is 24 hours from the time of referral. And then from that time of referral to us, a connection to a community health worker is done also within 1 to 2 day period. And we start services for that client very quickly after that. But all of the messaging and everything that is done from the time of referral is stored in this HIPAA protected environment. Again, we structure the contracts. We are responsible for all of the negotiating of fees, and we are responsible for the statement of work. But in turn, we also have contract agreements, business associate agreements, HIPAA agreements, and secure licensing for the community-based organizations that are going to be deploying their community health workers to service the client. So the strict process that we have from a contract basis really goes down all the way to the agency level and the community health worker level. So just in that process alone, you can imagine that there is quite a bit of information that's collected from referral to discharge of a client. And the timeline for an individual to be serviced from our program is really limitless. We encounter, though, most clients stay engaged with us for about 6 months, usually less. Our pregnant clients, if we really get them from first term to birth, they can stay with us for about maybe 10 months or so. And that's because even after they have given birth, we like to do a postpartum assessment and definitely want to make sure that they're on their way and their journey towards a healthy lifestyle for them and also for their babies. So in the last, this is just data capture from January of 2021 to May of 2024. You can see that we have an abundance of referrals, but we are able to support clients based on capacity. Not every referral is going to mean that they are going to participate in the program. This is a want to program, not a have to program. And we say that because the person who is being referred to us has to decide that this is the right program for them. It is a relationship. This is not a prescriptive model in that we receive a referral from one of our clinicians or one of our partners, and they've done a screen and they see that there are 5 or 6 needs. And when we receive the referral, we have to reconfirm or reaffirm that these are things that are needed in the household, but more so, what is the individual ready for? And so again, our enrollment activity is really going to be based on the factors of capacity, but also the individual wanting to be connected to the services and committing to this long-term relationship. For the most part, you can see that our pathways really, we open, and some of these could stay open for quite a bit. Each of the pathways is not only weighted for the dollar value, but we also have an estimation of time of when those pathways should be closed or should be completed. As an example, if we have an individual who comes in and we know that they can greatly benefit from an education pathway of some sort, maybe it is a mom who has just given birth, who is unsure about the benefits of breastfeeding. Maybe she was late to care and just really did not have any of those prenatal visits, didn't have formal education around this subject, and she expresses an interest. An education pathway can realistically be completed within about 1 or 2 days, and there's some standards around the timeline for us to be able to do that. That would be something that if we saw that an education pathway was taking much longer, it could compromise the integrity of that pathway. For things like housing stability, we would want to be looking at, on average, a housing pathway could be 6 months, could even be up to a year. So when we look at quality controls and we see that a housing pathway's been opened and then very quickly closed, we want to dig into that a little bit deeper. We want to know the insight of what's happening within that pathway and how we were able to really demonstrate that. What's most important is when we are able to see things that are not being met, things that cannot be closed, or they're closed incomplete. That allows us an opportunity to have a conversation in community about where we have a lack of resource. And this data collection is so specific, it could go down to a zip code level, and you could, in real time, look at the disparities amongst neighborhoods, amongst communities, and have a common conversation about what we could be doing better. More so, though, it allows an opportunity for us at the hub and the community health workers in the community doing field work to connect with the clinical providers to provide them insight about what their patient is experiencing and how we can work together to address those needs. We are currently working on an additional layer, which includes dual messaging for our Pathways Hub platform into the electronic medical record so that clinicians and care teams are able to very quickly see those non-medical drivers of health that are currently being worked on by our core team and community. By far, what we have found through our 5 years of service is that the social service referral is the highest used. These are going to be things like a transportation voucher, an emergency hotel stay, diapers for their babies, clothing, work clothes, anything that you can think of that is not connected to a clinical driver is held under a social service referral. And in our data system, we're actually able to pinpoint that even further down or drill the data even further down to see exactly what the true challenges are within a community. So again, in our 5 years, we've been doing a lot of learning, and that's just since deployment. We were doing a lot of learning even before we launched the program. But one of the things that we're super excited about is that we're not alone in this work anymore in Texas. We've got excellent and wonderful partners that are deploying and are growing their own Pathways Hub networks. And so I hope that they had an opportunity to connect with us today. But we do have a growing a Pathway Hub that is forming in Brazos County, as well as Harris County and Wilson County. And so we want to make sure that you have an opportunity, if you're interested in the Pathways Hubs that they are developing in those communities, We encourage you to have a conversation with these wonderful leaders as well. Although we are the more mature hub, we still consider ourselves a learning hub. And we're super excited to be a part of the Texas Pathways Hub network that is doing learning together, and that we are also leveraging resources, knowledge, and capacity. And so with that, I'm going to end the slide deck and pass it back over to Charles for any questions.
Thank you for that, Elizabeth. We did get a couple of questions come through, and I'm going to let the folks who posted them come on the mic. I'll start with Lynn Nguyen. Lynn, do you want to unmute yourself and just ask the question that you had about closed loop referrals? Lynn, are you there? Can we hear your voice on your question? Okay, I'm going to go ahead and ask what was posted in the chat there. She talked about, can you please provide more details on the closed loop referral, specifically how you can track if patients received the community resources and what resources they received? And can you link each with the NMDOH domain that the resource received?
Yep, absolutely. So through the assessment, let's just say that there is an individual who has expressed um, oh, that they've expressed that they have a food security need. They currently do not have enough food. Maybe this individual does not know if they are eligible for any types of services. The community health worker would open up the pathway, right? This is where the domain is, would open up the food security pathway. And they would start having the conversation with the individual about getting connected. Maybe they identify, because we're taking all the demographic information, the financial information, the family size information, all of that is captured at intake. We're very quickly able to see what they qualify for, what they might qualify for, and what they will not qualify for. We would recommend those programs and services that they are qualified for, and we would track and document that in our data system. If the client says, you know what, I think I want to go to that organization and I want to apply for SNAP benefits, great. The community health worker continues to track and document that the individual is going to set up an appointment to go visit with this agency to do their SNAP application. Then the community health worker will follow up after their appointment for the SNAP application. How was it? Did you attend? Did you go? How was your application? The client can say, it went great. My application is in. I'm expected to receive my card within a couple of days. Wonderful. I'll check back in with you in a couple of days. Check in a couple of days. How is it? Do you have a card? Yes. Have you started to use it? Yes, I have. How does it feel? What does that look like? Is your family safe? Yes. All of this has been confirmed, and now we know that there is a long-term sustainable solution to that food security need. At that point, we document where the client went, they kept their appointment, they received their SNAP card, they're using their SNAP card. Now we can close the pathway as complete and successful. So this program is not about just giving someone a phone number and that's it. This is not a directory. This is really about guiding and coaching individuals to identify a resource that they're best connected with, that they feel comfortable connecting to, that they continue the journey on their own, and that we are able to confirm or affirm that services have been provided. At that point, we close. So that's how we're able to ensure that we have the closed loop referral and we have evidence right in our data system to demonstrate not just the resource, but also the journey. What was that timeline? How long was it taking for individuals to get the service that they needed? I hope that answers your question.
Thank you. And on the topic of your data system, Joshua Collier had a question. Joshua, do you want to unmute and ask your question?
Sure. Thank you, Charles. Yeah, I'm just curious more about the data sharing and how it happens. We know that sometimes health data utilities or health information exchanges or community information exchanges can be a part of that data sharing. But we know it's complex in terms of the agreements required. And so I'm just curious how that works and at what point of contact is the consent obtained and have you run into challenges around that?
Sure. Great question, Joshua. So, our business associate agreement and our contract is really what allows for us to do data sharing. We've got a business associate agreement, HIPAA agreement. We also have, right, our contract that actually says this is how you will refer clients. So that is set up right at the very beginning. Now, because we're working with health plans, right, they're providing us PHI information, but we may not have access to an electronic medical record. So what happens on our side, which is something that we're deploying, is that the client, even though the client has been referred, and let's say that we receive them, they still need to consent to the program on our side. Most clients, because they have already been prepared, they've already been given information about the service and how it would work. Um, Most clients accept the help. Um, and we go through again a written consent from the client that shows that we are going to be provided authorization to access records, receive records or access records, and then we would send a message to our electronic medical record partner with this C3 HIE, which is our local HIE partner, and if a record can be found, they would be able to share information with us. And the information is limited to only what we need to know in order to be able to service the individual going forward. So we've taken an approach where we want to receive initial information, but the electronic medical record is not currently being shared by the payer to the hub. We're using our connected partner with it, which is our local HIE. And that's how we'll be able to do another phase, which is the dual messaging. Now, another thing I should mention is that part of the contract agreement is that monthly and quarterly, and then annually, we are sending a full demographic report with individual clients. How many clients were referred? How many clients do we have enrolled? What is the status of that client and their pathways. So our contract allows for us to be able to do that messaging and provide those detailed reports so that then internally, right, that organization is able to do their own reporting and their own risk assessment. So it does not interrupt their workflows. It's considered an additional tool that they can use to manage their clients.
Great. Thank you.
so much.
The next question we had was from Lori Long. Lori, do you want to unmute and ask your question?
I shall try.
We can hear you.
Hi, yes. So I love what you're doing. It sounds very similar to what we're doing on a small scale, but what we would like to do on a larger scale within our organization at Texas Health. And so I know a lot of the messaging that we share is really important to the different funders, because I understand there's various funders involved in order for sustainability to really occur. So I was wondering the type of messaging that you provide for the various types of funders. I'm assuming it's coming from all of this data capture, and you're showing that real ROI and service back to the community. So I might have missed some of that if you shared it, because I had someone call me at the time. So if you provided, I apologize. If not, I look forward to hearing it. Thanks.
So just to make sure I understand your question, you're asking how do we do the messaging back to the payer? Yep. Yeah, it's through those monthly reports. Every payer has their own scope of work and their own plan of engagement. And so we contribute to that. There are payers that like to meet with us in person monthly to go over case reviews with their caseworker team, those that are referring clients to us, and we can have conversations about the nuances, right, of a unique client profile. Data can give you a story, but really when you have conversation about the uniqueness of their situations, it really sheds different light. So our monthly and quarterly reports is definitely the data aspect that we're able to share. Those are electronic, but we also engage with our payers in a way of how do we do outreach or continued marketing for those specific populations? Are there maybe new integrations that we need to do, new tools, new assessments that they would like to see? Because they are actually looking at their claims data on the back end, right, and want to see other opportunities to support the client. So it is really a relationship with the payer themselves, and designing something that is very specifically tailored for their aims and goals as an organization.
And so all of the information again is being filtered. I'm trying to remember your map through you, that each party knows that it has to come to you. So you actually are creating the reports. They are having the data capture in some way, but you're creating those reports.
Right.
And can you share maybe 3 or 4 types of payers? So there's
Sure.
a differentiation that I think you
Yeah.
had.
We right now we have a payer agreement with Superior Health Plans, Aetna, Better Health, and Community First, and then a payer who's not a managed care organization, which is Bear County, and they're specifically asking us to support some of their child protective services families.
So the hospital systems, not necessarily you're really going through the insurance
We
as
have
your
a
payer.
hospital partner that we've just signed an agreement with our hospital partner that would be sending referrals to
Mhm.
us. Yeah.
Okay.
Yeah. So again, really, the ones that have really embraced this model have been the health plans traditionally, even, as the model has been intact for a while. But we are seeing a need in the hospitals to be able to deploy a partnership like this. Again, simply because they may have an internal workforce that is doing the assessment internally, and that is a process work of theirs. It does not interfere with whatever billing mechanisms they have in place to be able to do that. But it's what happens after they leave, right? Who is really supporting them for the longer journey? What we have found, and I'm privileged in the sense that we have the major hospital systems serving on our board of directors. Christus, Methodist, Health System, uh, University Health, which is our county hospital, right? So these board members and these community collaborators, even our federally qualified health centers, um, are looking at this, and they all say the same thing. We can do things within our infrastructure, but a lot of this work and capacity has to happen in community, right? Because
Mhm.
we're so strict for time. And so we're seeing an opportunity to really bring in more of our clinical teams, and have agreements in place to support their work.
And then I apologize. I'm going to one clarifying question, then give up the mic. The dollars are going back into the system to really, I'm assuming, um, pay for some of these community-based CHWs, because that's the capacity challenge that we see.
Mhm.
That's where the need is, and obviously there's not enough of them out there. So am I
Exactly.
right in interpreting that?
Yeah, yeah. The Health Collaborative, serving as the hub, is the one responsible for those contract agreements. And so the funding comes to the Health Collaborative. We in turn, through contracts, pay the care coordination agencies for the work that the community health workers are performing at the grassroots level. Yes.
Wonderful. Yeah. Okay. Thank you.
Yeah.
Thank you, Lori. Speaking of contracting, this makes me think, Elizabeth, when a new organization, a new payer approaches you, how long's that process of defining the scope of work and helping sort out, what they're looking for? How long does that take to get set up?
That's unique to the payer. I can tell you with our health plans, it's no less than a year, maybe a year and a half. You can imagine there's quite a bit of pieces that are internal to the payers to get something like this off the ground. Legal, right, and business associates need to be involved. Um, so that's about a timeline of about a year and a half to 2 years before a contract is executed with a health plan. Now, with a community organization or a clinical team, it could be a lot less, right? Because we're already working in community. Chances are we're already working together. We're seeing similar populations, and so we've seen, at least with for example, our county partner, it was a matter of a scope of work being developed, submitted to commissioner's court, and then getting it approved for funding. So those are very quick. Our hospital partners, I can tell you, as specifically with our Christus Santa Rosa, who is our first health hospital to engage, we're starting off with a pilot that includes some grant funding. that grant funding is going to allow them to test it, to see what it looks like, to feel it, and to also decide for themselves how do they want to use it and what adaptations should we be making in order to really support their care team. Once that pilot period is over, an evaluation can be had, and then we can start working on contract terms that are unique to that health system.
Great, thank you. We've got time for one or two more questions if anyone wants to use the raise hand feature to alert me. And while waiting for you to find that, I'll ask another question. You were talking about getting 400 or 500 referrals a month. That sounds like a lot. Talk about the community health worker capacity, like what defines their capacity, how much can they handle, what's that look like?
Absolutely. So when we're always recruiting, that's important for you to know. So as soon as we start seeing that we've got more referrals than we have capacity, this model really allows for us to be able to grow, right, with the amount of referrals that we're receiving and with the amount of yeses we're getting. Again, just because we have 1,000 referrals doesn't mean people are going to engage. So we really monitor that very closely. We have an internal team that is trained, and can act as a support to that flow while we bring in new community health workers. But on average, the ratio of a client to a community health worker should be at no more than 25 to 27 active clients. These are people that are enrolled, they're engaged, there are pathways that are opened, and we're working through them. Anything beyond that, we really want to make sure that we're supporting the community health worker and trying to keep them within that range.
Great, thank you. I was excited to see at the end of your presentation that this Pathways Community Hub model is kind of expanding in Texas, and we're seeing more of these grow. Can you just talk a little bit about how you interact with the other hubs and what that looks like?
Yeah, absolutely. I think our dream collectively in Texas is that all of our hubs are connected. We're in different geographies, and so we're definitely always looking for that. The think tank of the Texas Pathways Community Hub Network gets together at least once a month, and so we have these types of conversations about what can we learn, what can we leverage. We've been very open to share any of our best practices, contract models, anything like that. But I also have to say that the founder, Dr. Redding, and the Pathways Community Hub Institute, led by Jan Rima, just have really supported the growth in Texas. And so we're really working closely with them to have conversations about how we can expand the model, offer the services to other types of partners like our clinical teams, and how we could really best set up collaborative agreements with them.
Great, thank you. And one last question before we sign off here. Joshua had a follow-up. He was asking about how you evaluate the quality of CHW support and management, and specifically said, is this a resource being utilized? And he cites a CHW Center for Research and Evaluation tool.
Yeah. So because we act as hub, the control, right? The control room of all the activity. There are evaluation and there are metrics that we look for consistently. So community health workers, number one, and supervisors are required to have two learning opportunities, which is about maybe 2 hours at a time. So first and third Monday of the month, this group collectively gets together and we do case review, we do learning review. We're also responsible for ongoing training and skills assessment for those community health workers. We have benchmark reports that we've also established in order to ensure that we are doing quality over quantity. And so that's important for if we see that a community health worker is struggling, we are very quickly going to be able to see that in the outcomes. We're going to see that in the journey of the clients. And so our hub team, our coordinator, and our hub manager, this is what they do all day. They're in there, they're connecting with the CHW, offering additional training, offering additional support, bringing them back into the training bubble if we need to. But again, it is the hub's responsibility to continuously develop and upskill that community health worker from the time they enter to, hopefully the time that they mature and take up maybe new leadership positions within their organizations to train others.
Great, thank you. Well, I can't believe this time has flown by. There's so many great questions. I want to just turn over to our program manager, Jackie Klotz, to close us out.
Thank you so much, Liz, for your presentation, and to our audience here today for the really robust discussion we've had. Before we sign off, I want to alert everyone to the consortium's program index, which is a catalog of NMDOH programs across the state that are sponsored by health system organizations, including plans, providers, and hospital systems. The index features abstracts of programs with searchable fields, including program sponsorship, drivers of health, target populations, health conditions, location, and evaluation status. Our goal for this index is to serve as a resource for anyone working in this space to know what is happening, what is working, and with what costs and benefits. But the program index will be as robust as you make it. So I'd like to invite you to contribute to this effort by connecting with me at jk90@rice.edu to add an abstract to the program index that you are implementing at your health organization. The link to the program, and I'll add the link to the program index into the chat. And upcoming this week, our next learning session will be on Thursday, July 11th, looking at the use of evaluation for programmatic adjustment, presented by William Lyons from Legacy Community Health. So check out our events page at driversofhealthtx.org. Thank you all for this robust discussion today. We are grateful for your input, and we really want your feedback about this webinar. You will receive a short survey from us over the next several days. This consortium is going to be what we make of it, so we need to know what you want from us so we can deliver that. Please stay in touch with us. You can always reach me at jk90@rice.edu. Thanks again, and have a great rest of your day.
Thanks, everyone.